Good evening and welcome to the July 12th, 2023 meeting of the Board of Directors of the Washington Township Healthcare District. I'd invite you all to stand with me and join in the Pledge of Allegiance. I pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all. Public notice for this meeting has been posted appropriately on our website. Tonight's meeting is in person in the boardroom at 2000 Maury, Fremont, California, and is also accessible by Zoom. I ask that you mute your system until such time as you need to speak. We are recording tonight's regular session of the board meeting, and it will be posted on our website for future viewing. Cheryl, if you could take the roll for us.
Okay. Before I take roll, I wanted to note that the meetings of the Board of Directors shall be held in person. However, members of the Board of Directors may attend via teleconference under certain circumstances. In conformance with the District Board Policy Number A-017, Director Jeannie Yee has provided a written request of just cause to attend tonight's board meeting remotely by Zoom due to providing child care for her grandchildren. I will now take roll. Director Stewart?
Present.
Director Wallace?
Present.
Director Nicholson?
Present.
Director Epen?
Present.
Director Yee?
She was with us a little while ago.
She was with us, yeah. She's not there anymore. I think she's going to rejoin us.
I think she dropped off.
Storm, not
Yeah.
internet. She'll try one more time.
Okay. Note in the notes when we do it, she gets disconnected.
Okay.
She'll be back on. That's all we need to do.
So at the moment, she's
Back now.
Yeah.
Yes, but she's muted.
I'm gonna unmute her, Trees.
Can you unmute her?
I cannot, but I can.
Okay.
Can you unmute yourself? You're not able to?
You can record she's present.
Okay.
Yeah.
Yeah.
okay. Then we'll move on to communications. Members of the public are invited to speak during oral communications when prompted. Please state your name for the record, then proceed with your statement. Not to exceed 3 minutes on issues or concerns not on the agenda and within the subject matter of jurisdiction of the board. Are there any members of the public who would like to speak at this meeting? Hearing none. Cheryl, are there any written communications?
There are no written communications.
We'll move on to the consent calendar. The consent calendar consists of those agenda items that the board will approve with one motion unless either a member of the board or a member of the public requests to remove an agenda item from the consent calendar. If any items are removed from the consent calendar, the board will take action on the removed agenda item later under the action item heading of the agenda. Does any member of the public want to remove any agenda item from the consent calendar? Hearing none, is there any member of the board that would like to remove an agenda item from the consent calendar? Seeing none, then may I have a motion to approve the consent calendar items A through C?
I move that the Board of Directors approve the consent calendars, items A through C. Second.
I have a motion and a second. Cheryl, if you take the roll, please.
Director Stewart,
Aye.
Director Nicholson,
Aye.
Director Wallace,
Aye.
Director Eapen,
Aye.
Director Yee,
Hi.
Signal 5.
There she is.
We
Sorry.
heard you, Jeannie.
So
Thank you.
sorry. Had to reset everything after the storm, sorry.
Yes, only.
No problem.
So we just voted on the consent calendar. Do you agree with the consent calendar?
Yes, I heard that. Thank you. I agree.
Okay.
Thank you.
Good, that motion then passes. We now have a presentation on the Philippines Medical Mission, and if you could introduce that for us.
Sure, it's my pleasure to introduce two of our speakers. First, I'd like to introduce Dr. Carmen Akawili. She has been practicing medicine in Fremont since 1991. In 2008, she became the director of the intensivist program for critical care. Dr. Akawili is board certified in internal medicine and critical care. She's also a fellow of the American College of Chest Surgeons and a member of the Society of Critical Care. She is currently the medical director of the critical care and intermediate care units and is the interim medical director of the palliative care program at Washington Hospital, which began in 2016. Our other speaker this evening is Dr. Shekhar Srinivas. He is board certified emergency medicine physician. He was brought up in Northeast New Jersey and completed his BS in psychology with a minor in chemistry at the College of William and Mary. He went on to pursue a Master of Biological Sciences degree at the University of Medicine and Dentistry of New Jersey, and upon completion worked in a genetic immunology laboratory for 2 years, producing a couple of publications. He obtained a Doctor of Medicine degree at SUNY Upstate Medical University and completed his emergency medicine residency training at Drexel University College of Medicine. In his spare time, Dr. Srinivas enjoys traveling, cooking, hiking, and discovering music. Sorry. All right, Dr. Akawili, we'll turn it over to you.
Okay, I think Dr. Srinivas is having some visual problems, but that will be fixed later. Anyway, good evening, everybody. Thank you for giving me this opportunity to present my medical mission experience to the Philippines this year. So just to let you know, I'm part of the Philippine Medical Society of Northern California, which we've been doing a medical mission since 1986 for 37 years now to indigent population in the Philippines, around 4 to 6 hours away from the big city, mostly those with less access to care. So usually it takes about a year of preparation to inspect the place, the operating room, and the services. And we connect with the medical society of that place because we needed somebody to take care of our patient post-operatively. And then all the medical mission volunteers, when they apply, are credentialed, just like at Washington Hospital. And then also all of them pay for their own airplane tickets and for their accommodations and hotel accommodations. So that's what it is. We also, the Philippine Medical Society, take care of the licensing because we need a license to practice in the Philippines. All the medications are free and supplies as well. So that's why we collect donations from the United States. So my role for this mission was I was the medical mission committee chairman. So I'm supposed to, okay, there you go. So I was gonna show you initially cannot go back anymore, I guess. So this is, we got some leftover supplies. Go back one more, Sri. So just want to show you that it takes about 15 hours from the United States to the Philippines, and we're going to this little province of Pangasinan, Santa Barbara, Pangasinan. We have 7,100 islands. We have the big island, Luzon, Visayas, and Mindanao. About 9 years ago, I brought a couple of your surgeons, anesthesiologists to the Visayas Islands also for my medical mission. So the next slide. Okay, so Washington Hospital Foundation has given us the surplus or leftover supplies, those substandard for use in the inpatient and those that were not collected by the community. So I was lucky enough to have some PPE equipments, the face masks that are substandard, and the shields and some gloves from Washington Hospital that we collected it last year. And then the departure was January 12. We got a discount for our 30 boxes from the Philippine Airlines. Then we arrived after 16 hours. We lost 1 day, January 12. We arrived January 14. And then we still have 6-hour bus ride to Santa Barbara, Pangasinan. At least the bus is air conditioned. Then we have a side trip to the Jose Rizal, which is the national hero. And here I found Dr. Srinivas, that's him, and Athena, ICU nurse, who also went with us. We have 2 more, Gina Arguelles from the delivery, and 2 West delivery, and Aaron Arguelles, he's a clerk in the special nursery. So first day after preparation, there were 155 US volunteers comprising of 35 doctors. From the 35, about half of them were surgeons, 55 nurses, 10 dentists, 5 opticians. We have 4 biomed people, central supply, 3 pharmacies, 20 pre-med students, 10 of them were from Berkeley. And all the rest are our husbands and spouses who also helps with traffic control or data collection. So this is our first day. After we went and see the mayor of the place, we came here and the patients are already waiting outside. This is in the gymnasium, outside the gymnasium, and this is for optometry. So this is where we conducted our outpatient services. It's a big gymnasium, and we divided ourselves into, these are where the patients are being triaged. This is the medical part, pediatric. Here is the waiting area for pharmacy. Pharmacy is in below the stage, and on top of the stage is the data collection. So the nurses are triaging, taking the vital signs of the patient. My role, aside from coordinating, is also I was the urgent care physician at that time, because Dr. Srinivas, who's an ER doc here at Washington, has to go to minor surgery. He needs to do surgery. So this is the medical services. You can see some of us have a pre-med medical student that's doing scribe and also helping. We're also mentoring them for each patient that we see. This is the pediatric section on the other side. And the dental services were popular. Most of the time we did extractions, but for the first time we are doing now dental filling. So this is before and after. These are our dentists. He's a San Francisco dentist who brought his 4-man team helping out with these dental patients. This is our nice dental chair, if you see how uncomfortable it is, but it is what it is, and at least they are being taken care of. For optometry, which is one of our popular services, we have this volunteer optician with the autorefractor for our glasses, and the ophthalmologist for cataract surgery. We had 100 cataract surgery and about 1,500 optometric services. So these eyeglasses, reading glasses, were donated by the San Francisco Lions Club. There were 5,000 of them, and they're already graded. And some optometric services also, or specialists also gave us some reading glasses. And not new to us, but we have a volunteer chiropractor from Burlingame who brought 2 tables, and together with the occupational therapists and physical therapists locally, they were able to service more than 200 patients, preventive and also helping stroke patients. So our pharmacies, we have our PharmD, Catherine here, with 2 retired pharmacists as well, and some volunteers helping out with medication. Our budget was at least $15,000 for free medications for 1 week. We also was fortunate to have a radiologist from Kaiser who volunteered to read chest x-rays and ultrasound, so that we had these services, and we were able to get a mobile truck for the radiology equipments. So we had a special project this year that needed 1 year preparation. This is to maternal child care. We trained a couple of midwives, maybe 15 of them, to read ultrasound, at least to check if the baby is still moving, how the part's okay. So they were being trained like a couple of months prior to the 1 week of training, and this is the hands-on training for the midwives. They did it in the office and also in the field. So this is still being continued up to now, like Zoom training. Then on next year, we will probably follow up on them. We bought this local ultrasound, Chinese made, for almost $10,000. It's cheaper than the US made. So our big thing also is education, because we know we cannot just repair and cure patients. We need to kind of teach them. So we taught some of the allied health professionals, as well as the policemen and the drivers for ambulances, and some of the students about CPR, basic life support, and also about first aid, stop the bleed. We also have them. So these Berkeley students are helping our doctors. This is Janice Manjuk, who used to moonlight here as an intensivist, who was also with me helping out with the education. One thing that also happened during our mission is we have one psychology, doctor in psychology, who volunteered. And so she was doing one-to-one mental clinic as well as education. So this is our education team. Is a nurse certified ACL and BLS nurse from Highland, Janice Manjuk, the intensivist, and Milfi Ramos, the psychologist. So for minor surgery, I'm gonna let Dr. Srinivas move on and discuss here. We have Gina Arguelles here, who is the lead nurse. She is in the special nursery, but then she is the lead nurse for minor surgery. Okay, Dr. Srinivas, your turn.
Hi, everybody. Thanks for giving me the opportunity to chat a bit about my experience out there in the Philippines. It was fantastic. This is the second time I've been. First time I believe was 2019, went to Candon, which was even further north than Pangasinan, but great experience, great people, lovely patients, and different patient population, of course. And I was tasked to join forces with another surgeon to operate in the minor surgical ward. There's also major surgery and the medical ward that Dr. Ekawili had already gone over. But yeah, in this picture, this slide shows kind of our intake crew there on the left, super friendly, lovely, kind of managing all the lines, because the lines start at 7 in the morning, well before the clinic started, and lasted however long throughout the day for the whole week. And on the right gives you a little peek at what it actually looked like within the actual minor surgical room itself. We'll go to the next slide. So you have, this is a patient that came in, I believe an 18-year-old who was playing basketball on with slippers on, unfortunately, and then the slipper slipped off, and then he stepped on something about a week beforehand. He comes in, his leg is all swollen. He's got this gigantic collection there at the bottom of his foot, his right below his great toe, all wrapped up. And so we have podiatry, actually, that was incredibly great service for us. They were operating out of major surgery, but they were super busy that day. So numbed up, excised, debrided, cleaned, wound, and actually when you go down to it, the middle picture shows a pretty large open wound that tunnels down deep towards the bone, which I could stick my pinky finger in, and there's pus coming out of that. So cleaned it up as much as possible, packed, dressed, and luckily we saw him earlier in the week and had him follow up a couple of days later just to see how it was going, start him on antibiotics, and we just kind of redressed it. And that's the last I saw him. And I, had very specific instructions on how to follow up with the local clinic after that. But this is the kind of thing, of course, that we wouldn't really do in the ER here. You can go to the next slide. And there were plenty of patients that came in with other things that were a little bit less functionally issues. So, for example, a lipoma in the scalp that you're seeing here. One of the days, I don't remember which one, there were plenty of lipomas and a lot of them in the scalp. So we were joking that it was kind of like a barbershop and who wanted to get a new haircut today. But excising lipomas, excising fibroadenomas and sebaceous cysts, et cetera. And of course, using sterile technique the whole time. On the right is Gina's son, who works as a clerk in our special nursery, care nursery ward. And you can go to the next slide. The middle picture there is a 4-year-old with a pretty large soft tissue collection that we have x-ray services there. So we obtained that. It wasn't any bony involvement. Palpable pulses lateral to it. So this is something that we wanted to work on, actually, both the surgeon there and myself together. But unfortunately, they didn't come back. Mom didn't come bring the patient back. So got lost in follow-up. That last picture is to the right is a volunteer, actually med student who is currently in medical school locally in the US and whose mom is also part of administration of the Filipino Medical Society of Northern California. And you can go to the next slide. This gives you an idea of sort of how we made the makeshift minor surgical ward. It's essentially a small room with 3 beds back to back to back. Little AC unit, thankfully, was super helpful for all of us. Sterile technique, as you could see, the last bed was being used by a volunteer physician assistant who also works in the ER, but in the East Coast. And then you see some local L&D nurses on the right dressed in green that were helping and kind of moving around. What's not pictured is the entire right side that has all of our supplies. And there is a local medical student helping in the middle there. And you can go to the next slide. Some more pictures similar. The one on the left in the middle, that is Vernice. She is a recent grad in the Philippines, a medical student grad who's doing family practice and doesn't get to do any of these things. So just kind of doing some teaching, blunt dissection teaching, and horizontal mattress and different kind of suturing teaching, which was fun and very, very helpful. And on the right, there's some UC Berkeley students coming in and volunteering, just retracting and doing a little bit less, but definitely getting their hands in there as well. You can go to the next slide. And just some other lesions that we saw, maybe we know Mohs surgery is available over there. So some of these we would just excise entirely, whether that could be maybe a Meckel cell carcinoma, possibly on the left in the earlobe. It looks like I'm removing a sebaceous cyst in the middle, and unclear what exactly lesion that is. That's a lot longer, slower and indolent growing than a faster growing lesion on the right, but remove that. And as you can imagine, bleeding control is another kind of challenge there, but we had all the supplies that we need to make that happen. But yeah, we saw tons of patients. I'm not sure what the total tally is, Dr. Aquila, if you have that over the week,
Yeah,
but
I have it. It's 140 something, but I'll bring it later.
Yeah, we saw a ton, and it was an incredible experience. A lot of great teamwork, great attitudes, and it was an incredibly fun experience that I would certainly do again. So thank you for having me.
114.
114.
Yeah. Thank you, Dr. Srinivas. So,
yeah.
So I just want to briefly also show you that the major surgeries were done at the Pangasinan Provincial Hospital. Of course, we have our central supply and biomed team. They came like a week beforehand so that they can make sure that our anesthesia machine and the machines are working well. And what they did during is, aside from maintenance, is also repair some of the things that are needed in the hospital. So this is part of our supplies. And then we divided into operating 1 and 2, and the post-anesthesia care, which is the recovery room. So we have Athena here. She's assigned, most of them are critical care nurses in the post-anesthesia care unit. And I just want to show this to you, the old laparoscopic parts that we got from Washington Hospital that were assembled again by our part-time biomed Washington Hospital. We had a camera, we have the light source here, we have the insufflator. Those were the things that was we got from Washington Hospital, and this was just local, and he put them all together, so we were able to operate not this mission, but in the last mission, one laparoscopic case, and we needed more repair. Just want to show you that we're able to do some stuff with the donations that we get from you guys. Just want to briefly say something about this 8-year-old girl with a lobster foot or fingers. We found this in the pediatric unit. It's called electrodactyly. It's a genetic loss of absence or partial absence of toes and fingers. And the best option for this is a complete amputation. So after the consent, general anesthesia, they took out all the soft tissue. This is the foot, and this patient will have prosthesis after. And then, hopefully she can wear shoes and dance again. And this is our podiatric resident who took care of this patient, Corinne. Then the other one is an 8-month-old baby Mark who had this congenital glove fit, which we have done before also. So this is him after. So this is how it goes. They come in at 6 o'clock, check their cases, general surgery and OBGYN. Then these are the patients for thyroidectomy waiting for their turn. And this is how it is in the general surgery area. Dr. Beggy, what can you say? But we're trying our best to be sterile. This is our supply. But our blessing is a cesarean section with a baby. He said baby boy. So we had one baby out. And this one has to have a below the knee amputation. And this is our surgeon, anesthesiologist, and intensivist. This is Janice. And one Kaiser intensivist also. Our OBGYN, I didn't show any more pictures of the big, large masses. And of course, most importantly is our data collection, because my husband is there, Arnold, is statistician. So our husband joined us also to do traffic control and other things that are non-medical. So overall, I want to show you 30% is adult medicine. And then the next one is optometry, 20%. And then pediatric is around 13%, this blue one. And then the overall surgery is about 11%, the cataract, major, minor, and ophthalmology surgery. So we had the most was a thyroidectomy. We had 6 thyroidectomy and 6 total abdominal hysterectomy. We have ORIF, or open reduction internal decreasation of the ankle, 4 of them. We have also 4 of the cholecystectomy, gallbladder surgery. We have that. We have 1 bladder stone removal because we had a urologist. We had a hernia repair as well, and hydrocelectomy. So we had 41 surgeries in a week. And this is the minor surgery, 114 of them. Cataract, 169 of them. And then these are us. I didn't see a lot of patients because I was coordinating and doing urgent care. And for medicine, 1,799, pediatric, 772, ultrasound, 96, total of 165, radiology, laboratory, 271, we paid for the labs also, blood sugar testing, 55, COVID tests around only 12, and physical therapy, we had 247 patients. And lastly, for dental, we had 568, optometry with free glasses, 1,217, and special project about 122, a total for a week of 5,268 encounters. So that's it. I want to share this experience and thank Washington Hospital and the foundation, Kimberly, the board, for remembering the medical mission and giving us some of the surplus donations. Thank you all. That's it.
Thank you, Carmen. It's a very, very interesting report. You could correct me, but it looked like this was a larger program than what we've seen before. Is that true?
Yeah, it's more comprehensive, and we had more new projects like the teaching the ultrasound to the midwives, and also the ultrasound. So yes, it's larger and it's harder, but we were able to do it. And thank you all for your support.
Good job.
Yeah, very, very impressive. Thank you, thank you. Are there any other comments from the board?
Yeah, it's amazing.
Thank you. Thank you very, very much. It's impressive to see that kind of work. I was a dentist. I was impressed with the little girl you showed with the new teeth. That was remarkable.
I know we just don't want to pull now. We want to repair it. So
that does absolute wonders for a young child in their self-esteem and their ability to eat and their all manner of things. So what a wonderful project. Very, very nice to see that kind of thing.
And thank you all for your support.
Thank you. At this point, we'll move on to our reports part of the agenda, and we'll hear first of all from Dr. Mark Soleil, our new Chief of the Medical Staff, with the Medical Staff Report. Nice to hear you.
Good evening, everyone.
Nice to see you this evening.
Well, nice to see everyone here. Thank you so much. And I want to say that it is going to be my pleasure and my honor to be the Chief of Staff for the next 2 years. I think as you heard last month, Dr. Aaron Berry is the Chief of Staff elect, and he'll be the chair of the Credentials Committee. So you'll be hearing his presentations from Credentials in the next week or two. As well, I'll go right into the report. Basically, what we have here is the census. We have 590 total positions on the hospital staff. Of those, 333 are active, with the rest among various other specialties. I want to say, I have worked here for 2 years as a Chief of Staff elect, and I'm really looking forward to continued collaboration with everyone. We have lots of things going on simultaneously with the medical staff and with administration, with Ms. Hartz and the rest of the administration at the hospital. That includes getting ready for trauma, utilization management to try and streamline and minimize length of stay and improve reimbursements, and as well as the leadership development committee that's ongoing to get a pipeline of new, young, and interested leaders for future committees and positions such as this one. And that is a collaboration between the medical staff and the administration, including some training that we have upcoming in the near future in conflict management, in leadership skills, etc. That is my short and sweet report. Any questions?
We're looking forward to working with you for the next 2 years.
Thank you.
Now move on to our lean report. This will be given by Michelle Hudson, Chief Operating Officer of our lean.
Right, and then let me just give a brief overview or bio for Michelle. Michelle Hudson received a Bachelor of Science degree in Organizational Behavior and Leadership and a Master of Public Administration degree from the University of San Francisco. Prior to her role at Washington Township Medical Foundation, she worked in healthcare leadership, focused on operations, communications, and marketing, human resources, as well as program and fund development. Michelle came on board as Director of Human Resources in 2017 and became an integral part of Washington Township Medical Foundation. She became Director of Administrative Services in 2018 and was appointed Senior Director of Operations and Administrative Services in 2019. Michelle has recently been appointed Chief Operating Officer for the Medical Foundation, and she is going to talk about technology enhancement.
Michelle, can you unmute yourself?
All right, thank you. Thank you for that, Kimberly. And just to give a brief background on the Medical Foundation, I know many of you are familiar that we do see over 180,000 patient visits a year with over 20 clinic sites, and over 100 providers, both physicians as well as advanced practice practitioners. Okay. And then in terms of a background, we do provide wide-ranging services from primary care through specialty and surgical services. And we obviously partner closely with the hospital on inpatient surgical services, as well as ancillary services provided by the healthcare system. When we approach all of our process improvement work, but particularly with this technology work, there are various lean principles that we used, which really are the alignment of the improvement work to organizational priorities and strategic initiatives, really looking at that voice of the customer to see what it is they're looking for, clinic flow, engaging our staff as well as our providers, transparency and accountability, and PDCA, so plan, do, check, act, and continuously improving. Our daily management system is the tool that we use to help drive our improvement work. Our individual clinics have goals based on our organizational strategic plan, and there's a weekly discussion with how we're progressing on our projects, and that really helps leadership address any barriers. Our daily huddles really do help engage the staff in the current processes and improvements. This is an example of our frontline boards and our process owner boards. Those really help to define our priorities and show progress. We round on those boards as leadership, as well as the clinics do daily huddles on the frontline boards. So this is the WITMIF strategic plan, and here is how we link our technology to the strategic plan. So the technology infrastructure was central to our plan in FY23. And one of our cross-cutting priorities is really focusing on the continuous improvement work as well as patient experience. Since my chart really is the patient-facing side of Epic, we wanted to take advantage of the functionality that we have and then enhance the functionalities we were not currently using. So we decided to focus on 3 key areas, which are central to how we interact with patients. Appointment scheduling, making sure we've received all the needed information from patients before their appointment in order to streamline the registration process, and timely response to patient messages. So in terms of technology, many times we almost think it's just a matter of turning the technology on, but really there are many pieces that need to be in place for the build and the technology to work properly for our patients. We not only had to partner with the Epic team to get the build right, but we needed to make sure that we had the workflows in place in the clinic to make sure that the customers really had that seamless experience. We applied lean principles to this work. We got the input of the clinic teams. We did a survey with our staff and with our providers. We made sure that we knew what our patients wanted and made sure that we were using the new technology in the most efficient fashion. So in terms of appointment optimization, we know that patients want the ability to schedule appointments at a time that's convenient for them. We were also looking for ways to reduce the amount of time that patients were spending at registration when they came into the clinic. There were several challenges that we needed to work through when we opened up access for online scheduling. One challenge was to build template schedules in order for visit types to be scheduled in the appropriate slots for patient flow. When we went live with the new online scheduling, we needed to provide education to both staff as well as patients. We did, and then once we went live with appointment scheduling, we definitely saw there were some areas that we needed to make schedule adjustments. We also went live with e-check-in in order to reduce the amount of time spent on registration and paperwork in the clinic. That way, patients could go ahead and fill out forms before they came into the clinic. They could also confirm their insurance and their demographic information. We do need to get a lot of information from our patients so we can accurately manage their health conditions, meet our regulatory requirements, and ensure accurate and timely billing. The forms project and getting the forms online has been ongoing for some time, but we really accelerated this project in October of 2022. This included foundation-wide documents and medical components, making sure that those were standardized and consistent across all visits. Things such as health history and health information. We needed to standardize forms and questionnaires and put them into an electronic format. This required collaboration between physicians, operations, as well as Epic. so that we weren't just having patients fill out forms that we had to scan into media. This way they were actually fillable forms that transferred into the patient record. Again, one example was building fields into Epic to eliminate the manual entry and also reduce the use of paper in the clinic. In order to track the requests that were coming in, we wanted to move messaging away from phone calls over to MyChart. We also wanted to make sure that we were responding to patient messages in a timely fashion to ensure patient satisfaction and trust within the system. Many patients were used to calling in when we really wanted to move them to sending in messages, but in order to do that, they had to have their messages respond to and make sure that their issues were addressed. We not only worked on efficient messaging within the clinic by making sure the providers had all the information that they needed to take care of the message, but we also wanted to keep the patient informed in the process. So if the staff received the message instead of the provider, we wanted to loop back with the patient and say, thank you so much for your message. We forwarded your message on to Dr. Smith. We also know that there are competing priorities in the clinic. So there's messaging, there's various other things that the providers are responsible for. So we did want to incentivize providers. And so we included timely messaging response in their renewed contract. So how do we know if we're providing the services that our patients are looking for in MyChart? We really struggled with how should we track this? So we began tracking the number of times patients were logging into MyChart. So the theory being that if we were providing the services that patients were looking for, then they would continue to log in more and utilize the system. So last fiscal year, well, in FY22, our goal was for all of our patients that had MyChart to log in 3 times or more to the system. We met that goal last year. And so this year we decided to push ourselves and increase the goal to 5 times or more. So we did meet that goal, as you see, at least in May of 23, we were at 85.98% of our patients logging in. And so really, you know, enhancing MyChart is really helping to encourage our patients and providers to use that system for communication. And as you can see on this graph, you know, there were several interventions that have been put in place. So, you know, we went live with online scheduling for the urology and gastro clinics. We went ahead and put online fillable forms onto MyChart, and we went online with scheduling for PCP well check visits and annual visits so that patients could schedule appointments when they're convenient for them and not have to call into the clinic. The other thing that we want to make sure, again, as we mentioned, is that MyChart messaging and messages are closed within 72 hours. So, you know, we really started new work with the clinic workflow, you know, making sure that messages are forwarded, making sure that there was, you know, dot phrases and easy ways for staff to either respond to messages or get those messages to the appropriate providers. We did also put the metrics into our physician contracts. So we put them in our primary care contracts in October of 2022 and into our specialty contracts in March of 23. And so we've really seen an increase in the number of messages that have been responded to within 72 hours. That's really the benchmark that we're using. In addition to e-check-in, that's been something incredibly helpful for us as well, because again, it really gets a lot of that demographic and registration information before the patients come into the clinic. And it's also getting the patients to fill out the forms, again, when it's convenient for them, so they don't have to come in the office 15 minutes early and spend a lot of time filling out paperwork. So as you can see in May, we were at about 4,000 messages, 4,000 patients who utilized e-check-in, and that represented about 30% of our clinic visits in May of 2023. Are there any questions?
Well, thank you very much.
Okay.
It's very, very nice to see the progress on some of those things. Personally, I'm very much in favor of the e-check-in and the ability to, through MyChart, get all information that you normally would have to get on a phone call, talking to someone, whatever. Very, very nice system. Be nice to see that steadily increase and grow.
We agree.
Yeah.
at what point do you think we should start thinking about language barriers in our community? As you know, it's very diverse, and I just don't know what the experience is in terms of folks that can't read English.
Yeah. Yeah, and that would be, I mean, within our clinics, we do have solutions for that. We have staff with language capacities as well as providers with language capacities, and we do have a translation service. But it is something we should be looking at, you're right, for forms and for online services as well.
Do you know if Epic has such capabilities, or if it's used in other situations, other hospitals?
Yeah, I think that's something we can look into. I'm sure that they've been asked. I can't imagine. I mean, every place is using Epic, especially in heavily diverse areas like the Bay Area. I mean, so it has to be something that's come up, so we can absolutely look into that and what it would take to try to implement more of that. I think that would be great.
Any other questions or comments from the board? Again, thank you, Michelle. Very helpful tonight. Very interesting to see the progress. At this point, we'll move to our Service League report, hear from Sheila Vijay. Sheila?
Good evening, Dr. Stewart, and good evening, members of the district board. A greeting from all the volunteers. As always, the volunteers have been incredibly occupied this past month. For the month of June, 216 Service League volunteers contributed 2,399 hours to the hospital. We hosted a Friday orientation this past week, attended by 12 high school students, 26 college students, and 9 adults. Our Mended Hearts volunteers talked to 34 heart patients and 12 family members and caregivers. Recently, I had the privilege of shadowing Will Burdos, a college student who volunteers at our birthing center. From the very beginning, his mission, as soon as he entered, seemed very clear: to offer nourishment and baby diapers and volunteer-made gifts to the new moms who had experienced the miracle of childbirth. We approached each room with a gentle knock, respecting the privacy of the families. As soon as he walked in, Will greeted the new moms with a big smile and words of congratulations. His warm and compassionate demeanor immediately put the moms at ease, creating an atmosphere of comfort. The snacks he offered not only served as a source of physical nourishment, but reminded the moms that they were cared for and valued. To me, this experience served as a powerful reminder that even seemingly small acts of kindness can have such a far-reaching ripple effect, inspiring youth like him to continue to engage in selfless acts of service. When I asked his reasons for volunteering at the birthing center, I did find this young man very put together and very unusual. So I ended up talking to him for a while. He said, "The birthing center has been a wonderful opportunity for me to briefly peer into the lives of those who have given life to the next generation. Not only has it given me hours towards my credentials as a future nurse, but brings me a sense of satisfaction as I provide relief to the new moms. My goal in delivering snacks and diapers is to lighten the load for new moms, even if it's only just a tiny act of service. If a smile is all I receive," he said, "I know that I've done my job as a volunteer." Lastly, some sad news from the previous month. I was one of many volunteers present at a moving celebration of life event held on Saturday in memory of our beloved John Mena, who died on June 12, 2023. John began volunteering in 1992 when his daughter was awarded a 4-year scholarship, and he decided to volunteer as a way to thank the Service League for its generosity. He had intended to serve for about 6 months, but it ended up being 28 years of volunteering in the lobby, the nominating committee, and the surgery liaison waiting area. He retired from service in 2017. According to our records, we think that John was the first male volunteer in the Service League. John Mena a military veteran, was honored by the Navy at the event. He leaves behind Irene, his wife of 60 years, who is an associate member of the Service League, his children and grandchildren. That's all I have for you today. Please let me know if you have any questions.
Thank you very much, Sheila. The activity of the Service League is certainly going up. I was just curious, are you approaching the levels before COVID?
I believe so. I think so. We more so now because it's summer and we have college students coming back. Those who have been trained before have come back and they're serving. And we are quite happy with the progress we have made so far in terms of having volunteers. And also, and you're absolutely right, I think we'll be opening more areas for volunteering, which opens up different abilities of people. Not everybody want to be patient facing. Some like to be behind the scenes and still be of service to the hospital. So we do have various things we can offer to them.
This truly is a wonderful organization, great people. We'd invite anyone in the public to check this group out. They're a very, very fine group of people.
Absolutely.
John Mena.
Yes.
John Mena was very impressive. I loved that man. He was always pleasant to talk to. He was always just a really fine man to deal with. It's interesting to me that he was the first man in the Service League.
Yes, his service was wonderful. The service was so moving. I wish I had known him better, but I guess it's too late now. But I'm so glad that I went to the service. And so were many other volunteers who had actually known and worked with him.
Any other questions or comment from the board? Thank you. Well, thank you very much, Sheila. It's always nice to hear. Always nice to hear from the Service League. We'll now have a quality report from Dr. Beggy. Kimberly, if you could introduce him.
Thank you. It is my pleasure to introduce Dr. Ramin Beggy. He has concurrently joined UCSF School of Medicine faculty in the Division of Adult Cardiothoracic Surgery and assumed the position of Medical Director of Cardiothoracic Surgery at Washington Hospital Healthcare System since May of 2016. Dr. Beggy has practiced cardiac, thoracic, and vascular surgery for the past 22 years at UCLA, Stanford University, and UCSF medical centers, and has been practicing the entire scope of his experience and expertise. This includes repair of aortic aneurysms and dissections, minimally invasive and cardiac surgery for structural heart disease and coronary disease, and cardiopulmonary transplantation. He has served as the Director of Thoracic Aortic Aneurysms at UCLA, the Surgical Director of Lung and Heart-Lung Transplantation at Stanford University Medical Center and Lucile Packard Children's Hospital, and Medical Director of Cardiac, Thoracic, and Vascular Surgery at North Bay Medical Center. Dr. Beggy is part of our mission to offer patients the highest level of care available anywhere. To further that goal, Washington Hospital has a strategic relationship with UCSF Health and UCSF Benioff Children's Hospital. The focus is to create a comprehensive and integrated regional healthcare network. This includes providing Tri-City residents local access to many of UCSF's renowned specialty services, including cardiothoracic services, and providing expanded access to these specialized physicians. So thank you, Dr. Beggy, for joining us today. And I know Linda Antes is also available, and she's our Director of Cardiac and Vascular Surgery Program.
Thank you very much, Ms. Hartz, and thank you so much, board members, Dr. Smith, for inviting me to present today. And I want to also thank Linda and Linda Antes and Melissa to provide me with the data and for the slide presentation. I was wondering, Cheryl, I made some last-minute edits on the slides. I was wondering if I could share my slides by any chance so I can also advance them. Is that all right?
Yes, that's fine.
Thank you.
Please go ahead.
See my slides?
Yes.
Oh, okay. Thank you so much. So I was hoping today to present an overview of our program, cardiothoracic surgery program, and as well as some of the quality metrics that we have worked on to the board members. Our services that we are offering at Washington Hospital are myriad right now. For coronary artery disease, we offer both on-pump and off-pump coronary artery bypass grafting. Off-pump does not require cardiopulmonary bypass, and we can operate on a beating heart. As an aside, we have operated also on a volunteer at Washington Hospital using the off-pump coronary artery bypass graft technique. We operate the valvular heart disease surgery for both open chest and open heart procedures, as well as the transcatheter aortic valve. I'll have a brief presentation on the latter towards the end of my talk. We operate on aortic aneurysms and dissections, both for open procedures and endovascular procedures that would not require opening major body cavities for repair. We offer arrhythmia surgeries at this point, primarily as a concomitant procedure for other procedures like coronary artery disease or valvular heart disease or aneurysms. We also operate on patients with congenital heart disease that require both open and endovascular procedure and transcatheter procedures. With our partnership with UCSF Medical Center and UCSF Medical School for advanced heart failure, we have a collaboration with UCSF that we can transfer patients to UCSF expeditiously for things like heart transplantation and placement of an assist devices. Those are the services that we currently don't provide at Washington Hospital on site, but with our partnership with UCSF, we expedite the care of our patients with our connection with UCSF. This is the volume of our cases since 2013. These are the fiscal year volumes. They may require a little bit of an adjustment towards the end of July. So this year, our volume has been 118 cases. And I will explain that a little bit later, but these are in general include the cases that are primarily on-pump cases that require the use of cardiopulmonary bypass, as well as primarily coronary artery disease and valvular heart disease. There are also a number of other cases that we provide with our service line that are not necessarily included in those data. For example, in 2022, we did 21 additional cases that required our presence or our input and our expertise that include thoracic cases, both minimally invasive and open cases, mediastinoscopy, mediastinal resection of tumors and masses that are around the heart, endovascular procedures, and some major vascular procedures. So that number primarily reflects our cardiac surgery volume, which is traditionally has been reported as coronary artery bypass, revascularization, as well as valve disease and combined operation of those. If you look at the distribution of our cases, 85 of the 133 cases that were did in 2022 were coronary artery bypass grafting. So I'm sorry if the acronym is not familiar. The CABG, coronary artery bypass grafting, is the major operation that we do at Washington Hospital. So 85 of those procedures are coronary artery revascularization. These are patients who have severe multivessel or left main coronary artery disease that are not amenable for angioplasty and stenting. And if you look at the off-pump, these are the same operation that we perform on certain patients without the use of heart-lung machine on a beating heart. That's additional 4 cases. And after that, we do valve operation, both on the aortic valve and mitral valve, as well as occasionally on tricuspid and pulmonic valve, and the combined valve and coronary operations. So those are sort of the totality of our cases that we do that we consider to be cardiac cases. In addition to those 21 cases that are presented that are not normally counted, but this is the cases that we provide to our patients at Washington Hospital. If you look at the demographics of our patients, we are a bit different from the like groups. We present our data to the Society of Thoracic Surgeons, to the SDS, and we can compare our patients to the SDS-like groups. In general, there are fewer patients in our patient population that are women. We have 15%, and SDS data group is 22%. The demographics of our community is such that 54% of our patients are from Asian ethnicity and background, and in the SDS data group is only 4%. Diabetes mellitus is a little bit higher in our patient population, and so is chronic lung disease, which is probably about 2.5 times higher risk in our patient population than it is in the SDS-like group. And then also chronic kidney disease, which is twice as common in our patient population as it is in other groups. That would, in general, afford our patients a little bit of a higher risk of perioperative complications, but despite that, we continue to provide a similar outcome for our patients. However, on certain aspects of our risk factors, our patient population a little bit less risky. The use of tobacco is less in our patient population, and as is the risk of prior stroke and carotid occlusive disease. And the prior cardiac interventions, both open and percutaneous, are a little bit fewer in our patient population than are in the STS Society of Thoracic Surgeons like groups. If you look at the urgency of our cases, this is just looking at the coronary artery bypass grafting, the CABG cases. 70% of our patients last year were operated on as an urgent manner. These are the patients who are admitted to the hospital. They cannot be discharged until the operation is performed, which is statistically higher than the STS-like group, which is approximately 55, 56%. So that would contribute to some numbers that are later on we'll discuss. 70% of our patients being urgent, that means we operate on them as they are admitted, and then we wait a few days if they have to wait, and then we operate on them as opposed to coming home on the day of the operation. So one of the parameters that we were working on last year was our blood utilization. As you can see on the STS data group that are similar to ours, the utilization of blood was approximately 27%. We were as high as 41% in 2020. Most of was reflective of the fact that our patients stay in the hospital longer, and by the time they go to the operating room, they have some degree of anemia. And the secondly is also the ethnicity of our patient population that tend to be smaller than the STS-like data group, and they tend to have a higher requirement for blood transfusion. But with certain parameters that we use in the operating room and also post-operatively and perioperatively, we have reduced our blood utilization from 41% to last year being 16%, which is below the STS-like groups. Blood transfusion is expensive and also has the risk of reaction to the blood and potential other complications. So reducing the blood transfusion had been one of our goals, and we have attained it at least for the last year, and we'll continue working on this particular parameter. Another parameter that we are working on is the duration of the operating room. The longer the patient stays in the operating room, the more costly it would be. So the last year, the length of the operation was higher than the STS-like groups. And then this year, we have some reduction that is still within the striking distance of the STS-like group. That is a bit of a complicated, OR operation is a bit of a complicated parameters to calculate, because it reflects the time that the patient arrives in the operating room, is prepared for the operation, total anesthesia time, and the operation is complete and the patient leaves the operating room. So there are many factors that enter the duration of the operation. And of course, one factor is the duration of the operation itself and the complexity of the operation. But we will work on reducing our OR time and improving our efficiency at various aspects of the operation. So we will be at or below the STS-like groups of about 327 minutes for an average coronary artery bypass operation. Another parameter to consider is that in our group, we tend to do more bypasses per patient. So one patient may require 1 bypass, 2 bypasses, 3 bypasses, or 4. So if on the average, we're doing 3 to 4 bypasses, then the operation duration would be longer. And I'm not showing that data, but in our patient population, our average number of bypass grafts are 1.5 higher than the STS-like groups. I alluded to this number before. About 70% of our coronary artery bypass patients have already stayed in the hospital, and they are done urgently. So as a result, our total length of hospitalization is about 2 days longer than the STS-like data group, from 8 days to about 10 days. However, the days after surgery is the same and has been the same for the past 3 years or so. So after the operation, the patients stay in the hospital 6 days, which is similar to the STS and STS-like group like ours. Perhaps I can briefly talk a little bit about the transcatheter aortic valve. The transcatheter aortic valve is the procedure that we can replace the patient's valve who have aortic stenosis, severe aortic stenosis, without the use of heart-lung machine and without open sternotomy and without opening the patient's major body cavity, including the chest. This procedure was initially evaluated in the United States in about 2011 with the advent of transcatheter aortic valve, initially in the very high-risk patients, subsequently moderate-risk patients, and then finally in 2017 and 2018, the data came that even is an acceptable procedure in intermediate and low-risk patients. In general, the patients who undergo transcatheter aortic valve tend to be older. and would not be a outstanding candidates for open surgical procedure as it might be in a younger patients with the same problems. And it's also exclusively is for patients who have stenosis of the aortic valve, not insufficiency. So we started this procedure at Washington Hospital 2 years ago. January actually would be about 2.5 years ago. And then since then, we have done 56 transcatheter aortic valves at Washington Hospital. And then about 20 additional patients have been referred to UCSF. These are the patients who would require concomitant coronary intervention that we end up doing in a hybrid room at Washington Hospital, or perhaps for additional risk that I discussed before, the patient would be better off being at academic medical center as opposed to at UCSF. But of the 56 that we have done in the past 2 years, fortunately, we have not had any mortality and no significant cardiac mortality or morbidity and no complications with the device. 2 patients had developed a stroke. None of them have been debilitating, and both of them have developed stroke perioperatively, but had improvement since then. One of the risk factors for transcatheter aortic valve is the need for pacemaker. In the past 2 years, we have required 6 of our patients that would need a pacemaker because the heart would slow down or they develop some elements of heart block. And 2 of them we did during the same hospitalization, and 4 within 30 days of the operation after discharge. Initially, our length of stay after this transcatheter aortic valve was 2 days. Now we have reduced it to 1 day since this last year. And then 13 of these patients ended up getting readmitted for non-procedure related issues. These are the patients who may have atrial fibrillation or elements of heart failure, pneumonia, GI problems, but 13 patients have been readmitted and discharged subsequently. The main number for us is 0% observed mortality. Also, I just want to say, in comparison with the surgical aortic valve replacement, on average, the patients would stay about 5 to 7 days in the hospital, as opposed to the 1 day that these patients remain in the hospital. Also, taking into account these are older patients with an average age of about 76 to 77. The oldest person that we have done was 97, and the youngest patient that we have done with this procedure has been in the low 70s. So these are older patients who stay only 1 day in the hospital after the transcatheter aortic valve replacement. That has resulted with 115 clinic visits that we have seen for patients, and then 20 physicians in the community, cardiologists and primary care doctors have referred patients to us. Because of our outcome, Edwards has actually reported Washington Hospital as one of the referral centers for transcatheter aortic valve. I did this from San Mateo County, so it says within 21.4 miles of where I did this search, Washington Hospital is available for transcatheter aortic valve. Our telephone number is there, as well as the email number of our clinical coordinator, Kelly Franco. So the patients know that this service is available. And this is not through our website, but the website of the Edwards, which is the major supplier of a transcatheter aortic valve. Initially, we were not in that group, but since this last year, after reviewing our data, we have been added to that, so the patients can find us. So I just wanted to briefly talk a little bit about our affiliation with UCSF. Ms. Hart discussed that as well. As I mentioned, there are a number of procedures that we do for our patients, complicated valvular heart disease, coronary artery disease, structural heart procedures, electrophysiology, that we perform at Washington Hospital for our patients. And for certain services that primarily require admission to an academic medical center that in general include end-stage heart disease or advanced heart failure, that those patients will get admitted to UCSF. My colleague, Dr. Teng Li, who's also affiliated with UCSF, and I are usually able to expedite the transfer of these patients, perhaps provide the care to the patients at UCSF and bring them back to Washington Hospital for the period of recovery and subsequent follow-up. We also, about 2 years ago, we established a training affiliation with UCSF for our cardiothoracic surgery fellows. Some of them spend time with us. Currently, Dr. Andrew Wisniewski, he's one of the fellows at UCSF who's spending time with us. Dr. Wisniewski did his undergraduate degree at Johns Hopkins, subsequently did his medical school at UCSF, has done 5 years of general surgery training at UCSF, plus 2 years of additional research in aortic surgery at at UCSF. Now, currently, he's a cardiothoracic surgery fellow who does his rotation with us at Washington Hospital. So not only is a good experience for Dr. Wisniewski to see the scope of our practice at Washington Hospital, I believe this is also a recognition of the quality of our program that the Residency Review Committee approved that Washington Hospital would be added to the training of our fellows. In 2021, we started our collaborative clinic at Washington Hospital. In addition to the cardiothoracic surgery program, we also have cardiologists with structural heart expertise. Primarily right now is Dr. Harsh Agrawal, and also electrophysiology group at UCSF who are affiliated with Washington Hospital are seeing patients in our clinic. And then over 2,000 patients have been seen in our clinic since 2021. And we officially call our program Washington Hospital UCSF Cardiac Services, which is not only cardiothoracic surgery, but other services that we provide at Washington. So our hope is to have complete cardiac care for our patients. We do have Washington Hospital is designated as a chest pain STEMI center. So the patients can call 911 and they will be brought to Washington Hospital for evaluation of coronary artery disease if myocardial infarction or ST elevation myocardial infarction is suspected. Door to balloon time is a parameter that the cardiology and the chest pain center are guided by and also decided by their timely response. So we like to keep that time to less than 90 minutes. That means from the time that the patient from ST elevation myocardial infarction arrives at the door of Washington Hospital to the time that the culprit vessel is open with a balloon or angioplasty and stent in the cath lab, that the time should remain below 90 minutes, and we are attaining that time. The patients who are not amenable for balloon angioplasty and stenting, they are usually referred for coronary artery disease. Some of them can be discharged and come back for follow-up if they're elective. And some, as I mentioned, 70% of our patients remain in the hospital until they have their operation done. So if they are stable for discharge, we see them as an outpatient in our clinic. Our plan for the next few years is that to continue our training and educational affiliation with the UCSF. So hopefully the fellows will be exposed to the scope of our practice and the quality of our practice at Washington Hospital, and not only would benefit them, and also would be validation of our program. We would like to increase our marketing outside of our Tri-City regional area to San Jose and San Joaquin Valley. We have some connection. We're referring cardiologists in that group. As I mentioned, some 20 cardiologists refer patients to us from transcatheter aortic valve. We would like to bring some new procedures. I alluded to the MACE procedures for atrial fibrillation that we do concomitantly with other cardiac procedures. We would like to do a standalone operations for atrial fibrillation. That would initially incrementally and subsequently significantly will increase our volume. In addition to the transcatheter aortic valve, we would like to do other structural heart disease procedures that would include clipping of the mitral valve, closure of the left atrial appendage, closure of the atrial septal defect, ventricular septal defects. We do have the expertise and the equipment to do it. We just have to get our foundation of our program together. Washington Hospital strategically is interested in having Washington Hospital be designated as a trauma center. There would be a need for a cardiothoracic surgeon to be available for cardiac trauma, trauma to the pulmonary vessels, or traumatic aortic injury. And both Dr. Lee and myself are prepared to provide that service so we can maintain and attain and maintain that designation. I don't have any additional slides. I'm sorry if my presentation was verbose. I'll be happy to take any questions.
Nothing to apologize for, Dr. Deghi. That's very, very informative, very interesting, exciting to see what's being done and for the future ahead of us. Very, very nice things. Any comments or questions from the board?
I thought you did an excellent job, very thorough review.
Thank you very much, Dr.
It's very encouraging to know that
really-
we have these services available for our district residents.
So that was our strategic planning, Ms. Lee, that from the beginning we were hoping to accomplish the scope of our practice, basically duplicate what is done at tertiary coronary medical centers, the same in the vicinity of our patients. Our patients recognize that coming to Washington Hospital is easier, parking is easier. We have a 24/7 ICU, and we have cardiac anesthesiologists. Should they require heart transplantation, we can also provide that with our connection with UCSF.
Very good. Thank you.
Truly is exciting. Thank you very much, Dr. Beggy.
Thank you so much. With your permission, I'll leave the meeting at this point.
Thank you.
We're ready now to move to our finance report. Hear that from Tom McDonough.
How do I follow that?
Well,
thank you. I'm happy to present the May 2023 financial results. The inpatient average daily census was 146.8 on a budget of 134.9 for 8.8% increase, exceeding budget. Combined average daily census was 156.9 on a budget of 145, so over by almost 12. Admissions were 887 on a budget of 758, so outperforming by 129 or 17%. Patient days at 4,550 on a budget of 4182, exceeded by 368 or 8.8%. Outpatient observation equivalent days at 313 were below budget of 320 by 7 days. And our average length of stay was 5.3 on a budget of 5.52. So underperforming on average length of stay is a good thing, underperforming the budget. And so that's a 4% improvement. CMI, or case mix, index for May is 1.521 on a budget of 1599, a difference of 5%. So slightly lower acuity during the month of May. Deliveries for May of 144 were above budget by 26 or 22%. Total surgeries in May were 394, above the budget by 36, or 10%. And our cath lab cases were at 182, were under budget by 40, or 18%. Non-emergency outpatient visits of 9,633 were above budget by 929, or 10.7%. The emergency room continues to outperform budget with 5147 in the month of May on a budget of 4483, or almost a 15% increase over the budget. Moving on to surgical and cath lab indicators. Joint replacement, total surgical cases were 394 on a budget of 358, or 36 cases over budget. Joint replacement cases were 189 on a budget of 145, 30% improvement over budget. Neurosurgical cases were below budget by 4, while cardiac surgical cases were also below budget by 4. Other surgical cases performed on budget at 169. In cath lab, cardiac cases were below budget by 23, or 21.5%. Peripheral vascular cases were over budget by 19 cases. Non-vascular interventional radiology cases, or non-vascular IR, were below budget by 34, or 50%. While neuro IR were below budget by 2, at 5 cases on a budget of 7. Our productivity indicators Productive FTEs were over budget by 141, or almost 11%. Non-productive FTEs were over budget by 19.6, or 13%, at 167.5 FTEs. Total FTEs of 1624.8 were off budget by 160.6, or 11%. Total FTEs per adjusted occupied bed at 6.13 was positive to the budget of 6.38 by 4%. Total deductions, gross revenue was about 203 million at 2029 for May, above budget by $19.5 million. Inpatient represented 112.3 of that. Outpatient represented 90.6 million of that 203, which was above budget by 15 million. The preliminary payer mix, or the final payer mix, was 75.32 on a budget of 74.94, 40 basis points over. And then in the next section, provision for bad debt and charity, we saw a 2.36 on a budget of 1.9, and this was primarily due to several high-dollar private pay accounts. Patient revenue, again, is 203 million. Including other revenue, total operating revenue of 47.2 was 9.7 higher than budget, 9.7% higher than budget. Operating expenses at 46.9 million were 5.2 million, or 12.5% higher than budget. Salaries and wages were off 12% to budget, and of the 12.5% higher than budget, 8 of that is related to volume, and the 4% is variance due to not flexing the staff due to the volume. Employee benefits were slightly higher during the period due to employee medical and pharmacy claims. And then in supplies, we had a slightly higher expense in the pharmacy due to chemotherapy drugs. This resulted in an operating income of $285,000 and a positive operating margin of 0.6 for May, which was unfavorable to budget as we were looking for a 3.1% operating margin and 1.3 million in operating dollars. And that was the GASB version. I should have mentioned that. The FASB total net income is 213,000, or 0.5% margin. And FASB accounting, as a reminder, unrealized loss on investments, net interest expense, GO bonds, and property tax revenues are removed from the FASB report. So that's why the numbers are slightly different for both net income and net operating income. At negative 230 versus the positive 280. And then finally, the report on EBITDA. The organization continues to generate cash flow. In the month of May, we had 4.2 million in EBITDA, or an 8.9% margin, on a budget, though, of 5.25 and a 12.2%. Year to date, I will point out, though, that we've generated 47 million in EBITDA at a 9.3% EBITDA margin. And with that, my report on May's financial indicators is completed.
Thank you very much, Tom. Are there any questions or comments from the board on the financial report? Thank you. We now move on to our hospital operations report. Kimberly?
All right, I will present this evening the preliminary results for our last month of the fiscal year, June 2023. Gross revenue of $192 million for June was above the budget by $2.5 million or 1.3%, and was above June of 2022 by $10.6 million or 5.9%. Inpatient gross revenue of $106.3 million was below budget by $5.8 million or 5.1%, but $2.9 million or 2.8% above June of 2022. Outpatient gross revenue of $85.7 million was above the budget by $8.3 million or 10.7%, and $7.7 million or 9.9% above June of 2022. In June, the Radiation Oncology Center had $3.2 million in outpatient revenue. The average outpatient revenue is $3.4 million. In June, we had a total of 38 COVID-19 cases, and one was a newborn. There are 37 adult COVID-19 discharges represents 4% of the total discharges, and this was a decrease of 3 cases from the prior month and 48 less than June of 2022. So continue to see a decrease in the COVID numbers.
Newborn.
Yeah, we did have one.
Interesting.
Yeah. Moving on to key census statistics, the average length of stay of 5.4 was below the budget of 5.52 by 2.2%, and this was also lower than June of 2022 of 6. There were 9 discharges with length of stay greater than 30 days, ranging from 33 to 54 days. Excluding these outliers, the length of stay was 4.87. Still in-house at the end of the month, we had 6 patients with length of stay over 30 days, ranging from 32 days to 84 days. We do have one long length of stay with an individual with pneumonia and on a trach at this point. In terms of observation, outpatient observation equivalent days came in at 281, which were below the budget of 336 by 55 days or 16.4%, and below June of 2022 by 10 days, so 3.4%. Inpatient average daily census of 153.6 was above the budget of 145.2 by 8.4 or 5.8%, but below June of 2022 average daily census of 154.4. And then the combined average daily census of 162.9 was above the budget of 156.4 by 4.2%, but 0.7% below June of 2022. See by the admissions trend of 858, it was above the budget of 789 by 8.7%. June 2023 admissions were 49 or 6.1% above June of 2022. And mainly we've seen the favorable variance in medical cases. Looking at discharge trends, discharges similarly were 11% higher than budget at 876 for June. Moving on to patient days, the admissions are higher than expected, resulting in patient days of 4,607. This is above the budget by 250 or 5.7%. We had adult med-surg days were higher than budget by 100 days or 3.3%. Our OB-PED special care nursery days were higher than budget by 175 days or 43.5%. And really this was driven, we had a really high census in our special care nursery. It was over by 118 days. We had a lot of babies that were in our SCN. Also, as we've talked about over the past few months, we've been seeing the shift in ICU days to IMC. So IMC days, and this is our intermediate care unit, they were at 469. It's higher than budget by 126 days or 36%, and ICU days were lower than budget by 28.3%. So really a lot of the work that we've been doing in making sure our patients are in that appropriate level of care. Looking at total surgeries in June, they came in at 385 that were above the budget by 17 or 4.6%, and 24 or 2.6% above June of 2022. You'll see inpatient surgeries at 127 were below the budget by 8.6%, and outpatient surgeries at 258 were above the budget by 12.7%. Looking at our surgical activity broken down, You can see continue to be busy with joint replacement surgical cases. They were above the budget by 19 or 12.6%, and they were 5.6% above 2022. And you'll see later on, we also did 61 cases at the Peninsula Surgery Center in June. Neurosurgical cases were below budget by 4, 13.8%, and 3.8% below June of 2022. Cardiac cases were below budget by 8 and 50%, but were 100% or above June of 2022. And lastly, all other surgical cases combined were above the budget by 10 or 5.8% and were 7.1% above June of 2022. Talking about our cath lab trend, continue to have challenges in this area. Cases for June at 150 were 78 or 34% below the budget of 228 and 20% below 20 of 2022. As mentioned, we've been recruiting for new interventional radiology and vascular surgeons, and we do have a new IR and vascular surgeons that will be starting in the next few months. Just looking at our cath lab activity in terms of cardiac cases, they were below the budget by 35 or 33.3%. Our non-vascular interventional radiology cases were below the budget by 31 or 44.9%. Peripheral vascular cases were also lower than the budget by 10 cases or 20.8%. And lastly, our neuro IR cases were also below budget by 2 or 33.3%. So again, have challenges as mentioned in the cath lab. But working on it in terms of bringing in new physicians. Deliveries, we've had deliveries for June were 124, which is above the budget by 8 or 6.9%, and 4.2% above June of 2022. We did have a number of C-sections. They were 42.7% of total deliveries, which was higher than the budget of 32.8% of deliveries. Looking at our non-ER outpatient trend, non-ER outpatient visits of 8,649 were below budget by 272 or 3%, but above June of 2022 by 0.7. And really this was mainly driven by our lab visits that were down 23.6% lower than budget. And this is basically due to the change in our policy around COVID pre-procedure testing. So we're no longer testing all of anybody getting procedures or being admitted unless they have specific symptoms related to COVID. And this was offset by infusion center visits, which were 101 or 21% higher than budget. And X-ray visits were also above budget by 4.6%, along with increases in over budget of our perinatal diagnostic center, our respiratory therapy, and OB and outpatient wounds. And lastly, radiation oncology center began to operate in February, and there were 361 visits in June. And as we said, not included in the budget. Looking at emergency room, we've continued to be over budget. We came in at 4,683, and it was above budget by 140 or 3.1%, but we're 52 or 1.1% below the prior year. Moving on to our gross revenue recap, our surgical cases were above the budget by 4.6%, but revenue was below budget by 157 or 0.4%. I will say we did learn that we've had some late charges that were being posted in July, so we will we'll be following up on that so that given it's the end of the fiscal year, it will be counted into the June. We have room and board revenue, which was above budget by 3.3%. Patient days were higher than budget by 5.7%. However, as mentioned, our ICU days were lower than budget by 28.3%. Deliveries were above budget by 6.9%, and revenue was above budget by $250,000 or 7.6%. Emergency visits were above budget by 140 or 3.1%, and revenue was above budget by $213 or 1.8%. I will say when we looked at the different acuity levels in the emergency room, we did see an increase in lower level visits compared to the budget from that sense. Looking at cath lab, cases were below budget by 34.2%, and revenue was also below budget by 29.6%. And lastly, ancillary services revenue was above the budget by 5.3 million or 6%, and this was driven by the increase in outpatient activity as well as 3.2 million from the Radiation Oncology Center. Looking at our preliminary payer mix, you can see government-sponsored patient revenue made up 71.4% of total gross revenue. This was lower than the budget of 71.6% and lower than the prior year's percentage of 72.8%. HMO was 2.2% of gross revenue, which was lower than the budget of 2.6%, but higher than the prior year's percentage of 2.1% of gross revenue. PPO was favorable at 24.8% of gross revenue, which was higher than the budget of 24.2% and higher than the prior percentage of 22.9%. And lastly, private pay was 1.6% of gross revenue, which was consistent with the budget of 1.6%. Moving on to our preliminary productivity indicators, productive FTEs were above budget by 36.9 or 2.7% at 1,408. Non-productive FTEs were above the budget by 39.2 or 21.7% at 219.7 FTEs. Total FTEs of 1,627.8 were above budget by 4.9%. If you look at the total FTEs per flex budget, we were 30.9 or 1.9% over budget. So again, continuing to work on our flexing. However, looking at our productive FTEs per adjusted occupied bed, they came in at 5.08, which was lower than the budget of 5.58 by 9% or 0.5. That it was a little bit higher than 2% higher than the previous June of 2022. And then total FTEs per adjusted occupied bed of 5.87 were lower than the budget of 6.32 by 7.1% or 0.45%. All right, looking at our outpatient statistics, our witness clinic visits were below budget by 23.5% at 15,520 and 10% below visits of 2022. One main reason that in terms of why the visits were lower, they were 1,319 visits below budget, given that we were no longer doing the COVID visits through the Medical Foundation. However, we're still under budget in both primary care and specialty, and we had 3 open specialty positions, but we also had a number of the physicians taking vacation days during the month of June. Then looking at DevCo outpatient visits of 2,216, they were above budget by 4.9% for June, driven by our rehab center volume that was above budget by 12%. Our surgery center volume visits were below budget by 9.6%. As mentioned, our Peninsula Surgery Center visits, they were at 61, but was below budget by 41 or 40.2%. And Ohlone College Student Health Center visits were above budget by 23 or 176%. Moving on to the key financial statistics, you can see our days cash on hand ended at 148 days, an increase of 2 days from prior months. The increase in days in cash, we did receive supplemental funding that was offset by some lower collections for the month, and also some higher operating expenses. Our days in accounts receivable for June were 57.2. This is lower than the prior month by 0.1 days, even with the federal holiday in June. So as you can see, this was 6.4 days lower than June of 2022. And lastly, there were $167,000 in charity care adjustments in June of 2023. And then just last slide is our summary of unhoused patient activity. As you can see, for the 12-month period, there were 2,063 patient encounters, representing 995 unique unhoused patients. Of those 995, 312 had multiple encounters. The total unreimbursed cost of unhoused care is estimated at $5,659,000, and this includes food, clothing, pharmaceuticals, durable medical equipment, transportation, and other types of housing. So that's the report for June.
Thank you. Any questions? We'll move then on to our calendar report, Kimberly.
All right, I'll start with our July Employee of the Month, and it's Sandra Ureno from Environmental Services. And I'll just read a little bit about her. Sometimes a kind gesture, like visiting someone in the hospital, can lead to a life-changing event. Sandra Ureno was considering a job in another hospital when she visited a friend at our hospital. There was something about the welcoming environment that made her want to inquire about work opportunities at Washington Hospital. Sandra joined the Environmental Services Department in 2005, and since that time has been a wonderful asset to our organization. She has worked in the main hospital and in recent years was assigned Washington West, the 2500 Maury building. Over the years, her managers have received many compliments from finance, case management, ambulatory care services, women's center, and several other departments. Sandra's positive disposition and thorough work are appreciated by everyone in the 2500 building. Perhaps it's her background working with many types of people that helped Sandra enjoy working with staff from many areas of the hospital. She began her career in Guadalajara, Mexico as a teacher. After moving to the U.S., she worked for an electronics company in Fremont for 13 years. According to Director of EBS, Brian Fell, Sandra is a reliable, hardworking employee who stands as an inspiring example for others. Though it has been 18 years since she started at Washington Hospital, Sandra says it doesn't feel like it. She says, when you enjoy something you do, the years go fast. When she is not at the hospital, Sandra focuses on her family. She and her husband, Miguel, are proud of their 2 daughters, one of whom recently earned her master's degree, and the other is currently also completing her graduate work. Though they all have busy schedules, this Fremont family tries to get together every Sunday for dinner and family time. Congratulations to Sandra, our July Employee of the Month. It's always very fun and we really do enjoy going and giving out the award. All right, I'll move on and just talk a little bit about our calendar of outreach events. Just want to give a little bit of an overview from past events, June 14th through July 11th. Linda Antes, our Director of Cardiac and Vascular Surgery Program, presented at Acacia Creek on aortic stenosis, and 16 residents attended. Our Dr. Patricia Tenhold, pediatrician with the Medical Foundation, presented Feeding Your Baby During the First Year on Facebook Live and YouTube, and we had 69 live views and 267 viewed it later. We did kick off the Fremont Summer Concert Series, and we'll be there every Thursday. And we provided 100 free blood pressure screenings at that event. We also attended the Alameda County Fair Junior Livestock Auction. You'll see, I do want to thank Angus Cochran and our retired CFO, Chris Henry. They were both there. And we did purchase 9 hogs, 5 lambs, 3 goats, and a half a steer. And that will be going to for our patients and those and that in the cafeteria. And then also Maria Nunez on July 11th did education on stroke, and we have some pictures around all of these. So you can see our concert in the park, and that. Then we did also in the 4th of July parade, and you can see we had a lot of great representation from our volunteers. Next. Then our Alameda County Fair Junior Livestock Auction. You can see Chris Henry with our supervisor, David Halberth, on the right, and also with 4-H'ers there on the left. So we're very excited to be able to support the 4-Hers at Alameda County Fair. And then this was the presentation that Maria Nunes and others did for 50 students throughout the schools and Fremont and education on that, on stroke and other types of education. In terms of upcoming, again, we'll be at the Fremont Summer Concert Series this Thursday. We'll also be participating July 16th in the Mariachi in the Park Festival in Newark. Dr. Mustafa, our interventional cardiologist, on July 26th will be doing education on atrial fibrillation on Facebook Live and YouTube. And also, why don't we go to the next slide, you will see we'll be hosting Road to Wellness Family Health Fair, and you can see this is from 10 a.m. to 2 p.m. And it's going to be a wonderful event, and want to make sure that the community is aware. We will have a lot of participation from community organizations, but also from different services at the healthcare system too. I also do just want to make sure that our community and everyone is aware and this valuable resource for everyone in this community, and for anyone that is feeling signs, that knows of anybody or themselves feeling signs of risk of suicide. There is a free resource for anyone to take advantage of. They can call or text 988. This is something Alameda County, we're really trying to work with all the healthcare providers in the county to get this information out to the community. It's a really important resource, and want to make sure that everyone is aware. It's also, there's a way to visit it online at 988lifeline.org. And also want to say that the healthcare system through the Medical Foundation also has resources available too. So I want to just make sure everybody's aware of that. And just speaking of Concert in the Park, Dr. Stewart said a few words and was there at last week's Concert in the Park, and I believe Mr. Mike Wallace will be at this week's Concert in the Park.
There'll be more people from me then.
So we appreciate all of that, and just want to lastly remind everybody that October 14th is our 37th annual Top Hat Gala. And we're very excited to return to really our traditional way of doing Top Hat, and we'll have an elegant seated 3-course meal, live entertainment, and a garden cocktail reception. So save the date cards have gone out, and soon there will be invitations. So that is my report.
Thank you. Thank you very much. I'm excited about the coming Top Hat.
Yes.
To return to the elegant Top Hat affair.
Yes.
It should be a lot of fun. It'll be a lot of fun. There's no action to consider tonight. Announcements. Do we have?
No other announcements.
Yeah. And we have no more announcements. So there being no further business, this meeting is adjourned.